Morning, everyone. Thank you for coming and for being flexible about the change in room. I assume that other people are going to be filtering in, but we'd like to get started because part of this discussion today hopefully will energize the audience to be involved in speaking about the physical exam after we hear our presenters. You know, about 40 years ago, I was introduced to the dance of the physical examination during my second year of medical school by a wonderful, wonderful community-based practitioner in Chicago. And I still distinctly remember those sessions, standing there with my brand new white coat and my stethoscope that I couldn't afford and the ophthalmoscope that I couldn't afford but bought anyway. And I remember very distinctly thinking, the physical exam is what a doctor does. It is my tool, and it's my tool as a generalist more than any other tool that I have, an extension of my brain into my hands. But fast forward another 40 years, and now there's this controversy even in my own head. What am I doing when I'm examining the patient? Is this valuable to the outcome of the patient's visit, etc.? And so I'm conflicted right now regarding this wonderful dance of the physical exam that I think is so great versus the value of it is in care. And I think many of you may also be in that realm. Some of you may be anchored more on one side, that the physical exam is still the greatest thing in the world, and some of you may have given it up for the more specific diagnostic testing we can do. And so we thought we would have two very thoughtful, expert physicians take two sides of the coin and talk about it and let us think about it. What is the value of the physical examination? The title of the talk is the physical exam still relevant? I would keep it broad and say, let's rethink the physical exam. And our discussants today are two very well-known expert clinicians and educators, Greg Bump and Scott Hurley. Both are very active in the education of house staff and medical students. And they're going to present their views about the physical exam. And I'm hoping that everybody will feel energized by this to join in the discussion. So thank you very much, Scott and Greg, for agreeing to do this. Scott, you're going to lead?
Yes.
And we'll go from there.
So first off, I just wanted to thank you for inviting me to speak today on a topic that I really feel passionate about. So today's session is going to be structured as follows. We're going to start off by giving the pro side of the argument, is the physical examination still relevant? And I'm going to try to convince you that it is. And then Greg is going to give you the opposing view. And then finally, we want to make sure that we leave ample time for discussion, because I think that this is going to bring up a lot of talking points. So as I said, I'm going to be giving the pro side of the discussion, and as some background, if we step back to the early 20th century, eliciting a history and performing a physical examination, which I'll refer to as the bedside evaluation, was the most important means of physical diagnosis and diagnosis of medical conditions. Over the last several decades, the use of sophisticated imaging and diagnostic testing has dramatically increased, and that's accompanied a decrease in the role of the bedside evaluation. This decrease in the role of the bedside evaluation has been seen in a number of ways. For one, I think that we often see trainees and even our colleagues spending more time in front of the computer examining the electronic medical record than with the actual patient. Abraham Varghese has termed the virtual patient that's represented by the data in the electronic medical record, the eye patient. I think we've all seen incidents, though, where diagnoses that truly don't exist in the patient's problem list have gotten propagated and carried forward over time. Some people call those chartomas that grow with time, where insignificant tricuspid insufficiency now becomes severe tricuspid insufficiency. And nobody has really ever examined the patient and confirmed that being the fact. Tests are frequently ordered before patients are even seen. There's imaging studies performed in the emergency department. House officers will order 50 lab tests before they even go and talk with the patient. And I think the exam is viewed by some as being redundant because we have the three-dimensional imaging studies available that better capture what's going on in the patient's body in that view, and also as a burdensome requirement of insurance billing. I think Abraham Varghese summarizes our reliance on technology best when he says, if you come to a hospital missing a finger, no one will believe you until you get a CAT scan, an MRI, and an orthopedic consult. And this seems like an extreme example, but if you think to your day-to-day practice, is it really an extreme example? So my position is that the physical examination is still relevant and occupies a key role in patient care. We should continue to emphasize its teaching in our medical school curriculum. And I also want to emphasize that my supporting the physical examination and the teaching of the physical exam doesn't mean that I oppose or want to ignore using technology. I actually think that having really good bedside skills allows us to use the technology that we have available more rationally and appropriately instead of the indiscriminate ordering that we see so frequently nowadays. So the first reason that I think the physical examination is important is because it really is a vital ritual, and I think that this is often overlooked, but it really does have a true importance in our care of patients. So if you think of rituals, rituals signify rites of passage. They represent crossing of thresholds and transformations in status or commitment. And just to name a few examples, we have weddings, funerals, graduations. These are all things that really hold vital roles in our society. And I think of the physical examination as a vital ritual involving the transformation from sickness to health. And there are a lot of components of the physical examination that really make it a ritual. First, it involves two people meeting in a special place. That special place is the clinic or the hospital. Patients accept ritual by agreeing to disrobe and allow touch. These are really markers of vulnerability, and there's probably no other place in society where you could ask a patient to disrobe and touch them than in the actual physical examination. It involves ritualized garments and instruments. So the doctor wears a white coat, or at least should be wearing a white coat, and patients wear gowns. We use instruments, stethoscopes, blood pressure cuffs, etc. Examiners use unique terminology, so the terminology of medicine helps the mystical nature of the physical examination towards patients. And then also, I should say finally, trainees go through an apprenticeship in order to be able to perform it. So I think that there are many benefits of a properly performed physical examination that extend outside of its role in diagnosis. One is there's been a lot of documentation about the therapeutic impact of laying on hands. It helps to convey to the patient that she or he has received the examiner's full attention. It helps to strengthen the doctor-patient bond by affirming personal commitment between the doctor and the patient, the so-called therapeutic relationship. It helps to validate patient complaints by focusing attention on the body. It helps to establish confidence in the examiner. And finally, it fulfills patients' expectations. And I think patients truly believe when they walk into the doctor that they're going to be examined in a skilled, respectful, and ritualized manner. And a lot of the complaints that we hear from patients feeling that they've been shortchanged or not given enough attention result from the physical examination not being performed. I personally had patients say, wow, you're the first patient or the first doctor that's ever checked my blood pressure. You're the first patient or the first doctor who has checked my blood pressure since 1976. That's a specific quote of one of my patients. And I think that conveys to me that, they feel that I'm paying more attention to them. In the words of Sir William Osler, who's considered by many to be the father of modern medicine, remember, however, that every patient upon whom you wait will examine you critically and form an estimate of you by the way in which you conduct yourself at bedside. Skill and nicety in manipulation, whether the simple act of feeling the pulse or the performance of any minor operation, will do more towards establishing confidence in you than a string of diplomas or the reputation of extensive hospital experience. There's also a lot of negative consequences of a poorly performed physical examination. There's some preliminary evidence that it actually may have a nocebo or harmful effect, and that the healing process may actually be impaired. The process can be dehumanizing and degrading. Patients can feel shortchanged or like an afterthought. A lot of the complaints that my patient never laid their hands on me, my patient or my doctor didn't give me time, the time that I was hoping for, stem from this. And then finally, it can lead to a loss of trust in not only the physician who is seeing the patient, but in the whole medical system itself. So in addition to serving as a vital ritual, the physical examination is still a very useful diagnostic tool. There are many conditions that are readily diagnosed by physical examination, and this includes virtually all skin conditions, just to name a few. When you look at the literature, 80 to 90% of all conditions can be diagnosed solely by performing a careful history and physical examination, with the physical examination itself being responsible for about 10 to 15% of diagnoses. And you may say to yourself, that's a small number, but I think that even when a diagnosis is obvious by history, examination confirms the diagnosis and helps to rule out other possibilities. And I think that this number of 80 to 90% of diagnoses really stands out to me, because I know that we're ordering diagnostic tests in more than 10 to 20% of our patients. And I think a lot of that stems from the fact that we're not really sure what we're listening to or what we're hearing on patient interactions, and so we have to order more tests to confirm what we're uncertain about. So just a few notes. I acknowledge that the current evidence base for many examination maneuvers is weak or lacking. I think the fact that the evidence base is poor leads a lot of individuals to want to discard the physical examination entirely. And I really truly believe that further research is clearly needed to determine which findings are of high value and which are not. And I think that with an expanding knowledge base, we can then focus our attention on the useful maneuvers and discard the ones that aren't so useful. And despite this, though, I think that even without supporting research, many physical examination findings clearly have a lot of inherent value. So I also think that the physical examination plays a vital role in clinical reasoning. It serves as a hypothesis generating tool. And when performed skillfully, the physical examination can help physicians to both ask better questions of the tests they order and be more judicious of the ordering of tests. So I really look at the questions I ask on the history and the maneuvers I perform on the physical examination as being independent diagnostic tests that are helping to move me either closer to or further away from a diagnosis. So let's take a step back. This was a patient that I saw at the VA back in March. Of course, it was Friday at about 4 o'clock that I actually saw this patient. Mr. H is a 62-year-old man with hypothyroidism and hypertension who presents to his PCP for a regularly scheduled follow-up appointment with a complaint of a 2-month history of decreased vision in his left eye. He reports that the decreased vision developed gradually. Now he's unable to read out of his left eye, but he is able to distinguish light from dark. He denies any eye pain, headache, jaw pain, fevers, and malaise. And when he covers his left eye, his vision in his right eye appears to be normal. So the question that I have for the clinicians in the room is, do you feel comfortable performing an eye examination, including a fundoscopic exam? And I see a lot of heads going back and forth. Some of the more senior faculty are raising their hands. So we're going to come back to that, but on my physical examination, I found that the visual acuity in the right eye was 20/20. In the left eye, the patient was unable to read any letter on the Snellen eye chart, but he could see bright light. His extraocular movements were intact, his pupils were equally round, reactive to light and accommodation, and his external eye structures appeared to be normal. The fundoscopic examination that I did showed that the right retina was normal with a normal cup to disc ratio and normal appearing vessels. I was unable to visualize the left retina due to an opaque lens. So as I mentioned, this was 4 o'clock on a Friday, so I had to trust my physical examination skills that what this patient truly had was a mature cataract. Now, if I wasn't able to perform that eye examination, or if I didn't feel comfortable in my skills, I could have urgently called up my ophthalmology colleagues. They probably would have been a little upset that I referred somebody late in the day on Friday for urgent complaint that truly wasn't an urgent complaint. Or I could have even sent the patient to the emergency department, which would have led to a lot of medical costs that were unnecessary. I could have also gotten unnecessary diagnostic testing. I could have gotten an ESR and a CRP to evaluate for temporal arteritis. It probably, is not out of the realm that people that come in with vision loss to providers end up getting CTs of the head and MRIs and MRAs of the brain to make sure that they didn't have a cerebrovascular accident. So you can see how in this case, the inability to perform a physical examination could lead to a lot of tests, unnecessary urgent referrals, and healthcare expenditures. So I really think that the physical examination, as we move towards our high-value, cost-conscious care emphasis, really has a central role. I think that skillful bedside evaluation allows efficient gathering of diagnostic information. It can lead to us ordering fewer unnecessary tests. It can lead to a reduced number of unnecessary consults. And it can also lead to less emergency department referrals. And then I also think that it can avoid exposing patients to potential harms of testing. So these CT scans and x-rays are not without radiation exposure. And it can also avoid diagnostic delays. And ultimately, I think the patient is much satisfied if they can walk out of the clinic with a diagnosis in hand, as opposed to having to go through a bunch of additional tests, which they may ultimately find out were unnecessary when they meet with another provider. So, as I said, the ability to perform an accurate bedside evaluation permits more appropriate use of costly technology and could improve care. So this is really how I see the interplay between technology and physical diagnosis, is that I think the physical diagnosis and the physical examination can serve as the gateway to our use of technology and can help us use it more rationally, as opposed to the indiscriminate ordering that we frequently see nowadays. I also think that the promiscuous ordering of diagnostic tests will not be able to continue as we enter a new era of healthcare reform and accountability. I think one physician has summarized it best by saying, right now we have an unlimited menu without prices and we can order filet mignon at every instance that we want. I don't think that's going to be able to continue, and I think we're going to be judged more and more on the tests that we order. So I really think that because of this, we still need to be teaching our trainees, both students and residents, good bedside diagnosis skills, including history taking and physical examination skills. At Stanford, where Abraham Varghese is at, he has developed a curriculum called the Stanford 25, and they've commented a lot on their experiences from the perspective of the learner. They found that trainees are very eager to learn physical diagnosis skills. And I think the reason for this is I think that physicians really believe that they should be able to walk into a patient's room and know what's going on. It doesn't take a physician to order a lot of tests. I don't need to be a physician if a patient comes in with an eye complaint to refer somebody to ophthalmologist. I could have no medical background at all to say, oh, you need to go see an eye doctor. Learning and performing a skillful bedside examination from their experiences has also added satisfaction to the careers of their trainees and have brought about a change in attitude. And a lot of this data is still preliminary and based, but some of it has been published already by them. They've also found that in the era of duty hours and the need to be more efficient, that good bedside diagnosis skills can improve efficiency. Because if you know what you're doing, you need to spend less time thinking about what you have to do next. And then finally, I think it also has the consequence that it could promote more trainees to go into primary care fields, which I think with the changes that are occurring in our healthcare field, that there's going to be an increased emphasis on primary care doctors, and as a result of the numbers we have now, probably a concomitant shortage. So that's my viewpoint on why the physical examination is important. It's a vital ritual, it's an important diagnostic tool, and then I also think that it has the added consequence of it can enrich the careers of our trainees and doctors as clinicians. So these are just some references I thought you would be interested in. Now Dr. Bump is going to present an opposing view.
So before Dr. Bump talks, I want to leave some time for comments from, if you have some specific comments from what Dr. Hurley said and what Scott said, jot them down and we'll hopefully have some time afterwards to discuss those. But right now for kind of the continuity of the discussion, Greg will finish.
All righty. Well, thank you for coming this morning. So these are my views. I'm going to give them to you up front. I want to actually tell you that about 2 months ago, when I started to think about this debate, my initial response was, why do we really need to debate this? And the reason I thought that was that I actually think we're a great medical school. I think that we teach very competent physicians. I think all of our trainees do really, really well in the match. As a previous Pitt grad, I did pretty well. I'm a pretty decent doctor. So if it's not broke, why do we need to fix it? That was my initial response. And then I started to read more about the literature, and I'm going to show some of what I read about today. And I really evolved in how I felt about this topic. So as of really about the last 2 weeks, these are sort of my views on the subject. We spend way too much time teaching medical students about unhelpful physical exam skills. We should abandon the teaching of trivia physical exam skills and findings, and I'll give some examples of that in a few minutes. And I really think that time that we take away from teaching trivia, we should actually fill that time with more teaching about point-of-care ultrasound. And I'm going to talk about that a fair amount today. And really what I think we should do is to teach students about the intersection of clinical reasoning with point-of-care ultrasound. And I'm going to give some examples of that. Alrighty. Dr. Hurley's already done a great job of saying what we all believe, which is that the history is the most important thing that we obtain from the patient. Okay? The history is the most important thing that we obtain from the patient. The physical exam has been said to make the diagnosis in 10 to 15% of cases. I don't dispute that, but I want to highlight that the history is the most important thing that we get from the patient. And so I want to give an example. Alex, can I pick on you? Thank you. I'm going to present you a case. I know you didn't come here to get pimped today, but I know you'll crush this. I'm going to give you a case, and as you go through the case, what I want you to think to yourself is, what's my leading diagnosis of what I'm worried about, and what would be my next step, okay? So a 22-year-old college student enters the great race. During the run, the student feels lightheaded, and in the final mile, he gets nauseous. He says, hey, only 1 more mile to go, I'm going to keep going. He runs, he passes out. This is downtown, there's people everywhere, and he is reportedly unconscious for 2 minutes. It's Pittsburgh, so he goes to the emergency department, and in the emergency department, he's examined by an early M3. Not a bad M3, but an early M3. And the M3 gets an EKG, and she says that it's unusual to her, with larger QRS complexes than she normally observes, and she believes that there's a soft murmur. She can't tell you systolic or diastolic. She's not that comfortable with her exam skills yet. So my question for you is, what diagnosis are you considering?
Number one diagnosis.
HOCM. Okay, perfect. Hypertrophic cardiomyopathy? Okay. You're pretty smart. Would you evaluate the patient any further?
Yes.
This is audience response. I never know what people are going to say. You may say, send him home. He's doing fine. Just don't run the great race next year. I don't know. What diagnostic studies would you pursue?
So while we have wonderful M3s here, I do personally like to do my own physical exam. So I want to know where the murmur is. So the point being, my initial diagnostic solution is that this gentleman has a structural problem with her. So I'm going to listen to him, but I'm probably also going to get it.
Okay.
Among others.
If there's a murmur present at all, would you order an echo?
Probably.
Okay. I'm going to speculate probably, definitely, right? Okay, fair enough. So, how many cases of HOCM have you personally seen where you've made the diagnosis de novo? Not somebody else has made it and you're following up on it, but you've said, hey, today I'm diagnosing HOCM. I would hope that you've seen HOCM.
I think I had one on the pediatric side.
I've never seen it where I've made the diagnosis myself. I've been in practice for 15 years, okay? But you've heard the story enough times that you correctly arrived at the right diagnosis. And what really gave it away here for you was the history, right? The history. And so if we ask ourselves a few questions about the physical exam, would your management change based upon whether or not the murmur changed with Valsalva? You don't have to answer that question. It's rhetorical. But for me, I can guarantee you it wouldn't change. And we teach medical students like they're supposed to squeeze the hands or do something crazy like that. And, I wouldn't really change my order of an echo regardless of what happened with hand squeezing or position changes, okay? This is not to say that the physical exam is not relevant. It is, but I think that we really should highlight that it's relevant for very obvious things, okay? The physical exam is relevant for very obvious things. So the guy with the skin rash, that's shingles. The black guy is a visual depiction of knuckle rigidity, okay? The knee is a person with a big knee effusion, and the eye is a person that has a subconjunctival hemorrhage, okay? These are all obvious physical exam findings, just like the cataract that Dr. Hurley showed us, and we should clearly teach people obvious physical exam findings, okay? But unhelpful physical exam findings, let's talk about a few. I know Dr. Follensby knows what Demusset's sign is, but this is the head bobbing that occurs with aortic regurgitation. Quincke's sign is this funny thing in the pulse, and Traub's sign, if you ever happen to listen to pistils over femoral arteries, this is apparently what it sounds like, okay? I don't do that a whole lot, so I wouldn't know it if I heard it. But we never let patients get to the point that they develop these physical exam findings anymore because we've already corrected them surgically, okay? We don't wait until patients say, yeah, I know that you think you've got horrible aortic regurgitation, but your head's not bobbing yet, and hence I will not refer you to a surgeon, right? Why do we teach this stuff? Appendicitis? We no longer wait for people to develop a Rovsing sign before we say, let's go to the operating room. We take them to the operating room 36 hours before these signs develop, okay? So those are examples of what I call trivia physical exam findings. But if you think about other things that we do for people that have dyspnea, we teach all this kind of stuff in medical school. And I'll be honest, the only time that I demonstrate these physical exam findings is when a student is with me and says, do you think there could be tactile fremitus? And I'm like, who cares? But then I said, well, let's go ahead and I show them how to do that, okay? I show them how to do that. So these are what I'm going to call unhelpful physical exam findings. Why do we teach these things? Why do we teach these things? I think that we do these things so that we can have measures by which we can say this medical student can memorize more than that medical student and hence must be better. I think we also do it for one-upmanship so that we can say I'm better than this doctor because I can articulate more rare physical exam findings. I do think that we do it to teach culture and to teach history, and I do think there's a lot of value to that. But I think the main reason that we do this is that it's tradition. And like a lot of traditions, there is a time for those traditions to go away. So, this is a pretty famous study. This was published in JAMA in 1997. This study was published when I was a third-year medical student. I actually read this. I remember hearing it on NPR at the time. And basically what they did with this study is they played residents and students audio tapes of patients' chests. And then they said, let's take a physical exam, or let's take a multiple choice exam and see if you can guess what this murmur that you heard on a headset said it is. And I want to highlight that the students and residents did pretty bad on this test. They only got a 20% right, okay, 20% right. So when I read this as a third-year medical student, I said, I'm not going to be one of those people. I'm really going to get good at the physical exam, okay? And I came back and I read this article again about 2 weeks ago, and I had this kind of response. So if Einstein could tweet, this is what I think Einstein would have said about this, okay? Why do we ask students to be awesome at listening to an audio tape of an Austin Flint murmur when they have never seen a patient with aortic regurgitation? I don't know why we do it. We should expect Dr. Follensby to crush that test, but why in the world we would expect a second-year family medicine resident to be able to know exactly what an Austin Flint murmur is? I just don't think it's a reasonable yardstick to put people up to. All right. So Henry Ford is a pretty smart guy. Henry Ford had one of the biggest impacts on modern society ever. And what he had basically said is if I asked my student or my customers what they want, they would say faster horses. If you ask a physician whether or not students should be better at physical exams, they would say, yeah, of course they should. They should be better at it. But the question is should we continue to try to make people better at the physical exam, or should we instead think about innovative ways of doing things better? All right. How many young people in the audience know who the cartoon is? All right, fantastic, fantastic. So when I was 12, my parents for Christmas got me a Texas Instruments computer. That's a picture of it. All that thing did was annoy me. I would buy PC World magazine. I would type in 1,000 lines of code. I would think, I'm going to get this great Space Invaders game that's going to play. I would hit run, error, line 1. I'd correct line 1. Run, error, line 2. I was never able to get my Texas Instruments computer to do anything other than annoy me. Okay? At the same time, the Jetsons were a cartoon, and the Jetsons were really forward-thinking. The Jetsons invented FaceTime. This is Mrs. Jetson and Mr. Jetson FaceTiming. Okay? And they were even smarter than FaceTime. Wireless FaceTime. There's not a single cord on Mrs. Jetson's FaceTime. Okay? So, in the pace of 30 years, I can FaceTime people now. Unbelievable to think of in 1982. Okay? Unbelievable to think of in 1982. People looked at the Jetsons and thought to themselves, not a chance in heck. Okay, folks, we're there. So, I think it's time to ask the question, should the ultrasound replace the stethoscope? Is it time to start thinking forward like the Jetsons did and think about point-of-care ultrasound? Point-of-care ultrasound is with a handheld device. It's done at the bedside. It's done with minimal teaching, and it's aimed at making a specific diagnosis for a well-defined scenario. Why should you do it? Here's some reasons. Number one, students like it. Students like to learn about physical exams. I think students like to learn about lots of things, okay? I've read a number of studies about point-of-care ultrasound. They've been done with hospitalists, residents, students. Everybody likes this technology. There's probably a lot of publication bias so that people who hate this technology don't write their studies up, okay? But it seems very practical and feasible to teach people how to do it, and they seem to like it. It actually improves diagnostic accuracy. So remember that study where 20% of residents got the right exam, the right questions about murmurs? This is a similar sort of study where actually what they did is they had patients in a hospital who had cardiopulmonary complaints, and they got cardiology consults. And what they did is they had the patients be examined by students who had learned how to do point-of-care ultrasound. And the question was, does this patient have an abnormal cardiac exam? Was essentially the question that was asked. And then these patients also got seen by board-certified cardiologists at UCLA. Not a bad medical school. These are good cardiologists that they were being seen by. And the question was, does the patient have valvular disease of at least moderate severity or greater? Not trivial MR or trivial TR, but honest to goodness valvular disease. Wow, this is the data. So in the black is how the students did with their point-of-care ultrasound, and in the white is how the board-certified cardiologist did, okay? The board-certified cardiologist only got the right answer 50% of the time, okay? 50% of the time. The students clearly outperformed them, and really much more so for diastolic murmurs. All right, so it helps you to make a diagnosis more accurately. Does it actually change decision-making? So this was a study that was just published last month. It's not out in paper yet. It's just out in the cyberspace. And this was a study that was done in Europe where they had nurses who learned how to do point-of-care ultrasound and evaluating patients with heart failure. So this is the flow of the study. It's hard to read this in the back, but essentially it was a randomized controlled trial where patients came to an outpatient heart failure clinic, and the patients were randomized to be seen by two nurses. One nurse used point-of-care ultrasound, and the other nurse did not. But both nurses did a history, a physical, lab work, all of the stuff that you would expect to have done when seeing somebody for heart failure. And what they did in the study is they flip-flopped the nurses so that one day the nurse might be the point-of-care ultrasound nurse, but the next day they would be the non-point-of-care ultrasound nurse. And then what happened is the patients then also got seen by a cardiologist. All right, so they compared how well the nurses agreed on certain features of the illness. So they asked the nurses what was the patient's New York heart classification, and they agreed 82% of the time. That's pretty good. They said, does the patient have leg edema? This is a yes or no question, okay? And they only agreed 74% of the time. That's not too good in my opinion. What's the patient's volume status? Are they euvolemic, hypervolemic, hypovolemic? It's a pretty important question in heart failure. It's something we beat into trainees' heads all the time that they should assess. And they only agreed 63% of the time. And if you look at that kappa statistic, that's actually pretty poor agreement. And then the other thing that they asked the nurses was, would you change the diuretic treatment for the patient? And there again, they only agreed with sort of, good agreement, not all that great. Why is it important to even make this decision? Well, the patients, what they found was that patients that had any pleural effusion, that's this, any pleural effusion, those patients that had any pleural effusion by ultrasound did worse, okay? They did worse. And the patients that had a big dilated inferior vena cava also did worse, okay? So what they found in this study was that assessing them by point-of-care ultrasound actually led to changes in the diuretic management, and it was the single biggest predictor that they had in this study, okay? This study is not a perfect study. It was a short study. It was a small study. They do not have patient outcomes yet, but I envision that that type of research is going to be coming soon. All right. This is another interesting study that looks at testing. And basically what they did in this study was they compared two ICUs that had point-of-care ultrasound that they used all the time in clinical decision making, and in the other study they had point-of-care ultrasound that they only used for procedures. And essentially what they looked at was, does point-of-care ultrasound lead to more and more testing, which is, I think, something that Dr. Hurley raises a potential concern. So this is an American study. This was done at North Shore University Hospital and Long Island Jewish Hospital, so 2 ICUs basically in New York. And this is just their table 1 that essentially says that the 2 groups were pretty similar. These are the main results of their study. So what they found in this study, I hope you can tell by all of these ridiculously high p-values, is that the ICU that used point-of-care ultrasound actually used a lot less testing. They used less chest x-ray, less CT, less DVT scans, and less cardiology-obtained TTEs. Not a randomized controlled trial. You're looking at apples and oranges, but this is some preliminary evidence that suggests that point-of-care ultrasound may decrease the obtaining of other tests. All right. I've talked about point-of-care ultrasound like it's novel and it's new and it's exciting, but we actually have been using point-of-care ultrasound for like a decade or more. And I'd like to give some examples of where we've already been using this, and it's extremely well accepted. So if you're a trauma patient and you come to our ER, you get a FAST scan, okay? And that FAST scan is done by a surgical resident, okay? It is done by a surgical resident, or it may be done by an emergency medicine resident. So we are already training people how to do this, and they do it really, really well. Increasingly, people are using something called the extended FAST scan, or EFAST, which also examines the chest as well. And there's a lot of new evidence coming out that your ability to identify pneumothoraces is much better with an EFAST scan than it is with a plain chest x-ray. And there's also evidence that it helps to denote hemothorax and hemopericardium. ICUs all across the nation are starting to use the RUSH protocol, which is a protocol where we ultrasound people with shock, and we try to distinguish if they have cardiogenic shock, hypovolemic shock, or septic shock. And there's some data coming out that says that this really helps people to make better decision making in volume resuscitating shock patients. Out in the community, we actually do community fairs where we screen people for aortic aneurysms, and this is oftentimes done by nurses in the community. So there again, you've got people that can learn this pretty efficiently. And it's worth noting that all of our residents at UPMC who do procedures learn how to do procedures with ultrasound. So we're doing this already. And on my own experience on general medicine, we use the ultrasound machine all the time to look for ascites because we acknowledge that this is better than the physical exam. All right. I wanted to leave time for us to have an open discussion about this. And so I went through this stuff quickly, and I hope that you were able to take away these thoughts, or if this is what I wanted you to take away. Training providers to do point-of-care ultrasound is practical and well-liked. For certain conditions, it is clearly better than the physical exam, and I'm going to say that's true for a lot of cardiology. I think there's a lot of evidence in that field. I think that it can improve the care that we provide. I think it may decrease the use of other resources, and in particular, ionizing radiation. There's a lot of stuff in the radiology literature now that we want to reduce the number of CT scans that we give people because of the risks of cancer. There's no convincing evidence yet that point-of-care ultrasound improves outcomes, but I think you're going to get that data over the next 5 years. And I think that it's time that we accept innovation. We stop asking people to just have faster horses, and we instead think about other ways of doing things to solve clinical problems. And so with that, I will accept any questions.
So, thank you very much. Maybe